Your tests came back normal. Blood work fine. Scans clear. Doctor looked at the results, looked at you, and said, everything looks good. But you do not feel good. You feel like something is quietly, persistently wrong, and you can't find the words for it. Not dramatic wrong. Not emergency wrong. Just off. All the time. In ways so vague you've started wondering if you're imagining them. You're not imagining them. That feeling has a name. 2 of them, actually. And by the end of this, you'll finally understand what your body has been trying to tell you. Before we go any further, I put together a symptom map that helps you connect these invisible feelings to actual patterns. Because that's the problem, isn't it? Not that the symptoms aren't real, but that they don't connect into anything you can point to. Type symptom map in the comments and I'll send it directly to you. Most women who go through this know something is wrong long before they have the language for it. This map gives you that language. Keep watching. By the end of this video, you'll understand exactly why you need it. Let me describe something, and I want you to notice if any of this sounds like your life. You wake up in the morning and the first thing you feel is tired. Not groggy. Not the kind of tired that dissolves after coffee. Actually tired. Like you went to sleep exhausted and woke up the same way, and sleep did not do what it was supposed to do. You lie there for a moment and you think, I just slept 8 hours. Why do I feel like this? You get up anyway, because that's what you do. You get through the morning. But by early afternoon there's this heaviness that sets in. Not sleepiness exactly. More like your body is operating at reduced capacity. Like someone turned the voltage down slightly on everything. You can function. You are functioning. But it costs more than it should. Your eyes feel dry. Not dramatically, just slightly. Irritated in certain rooms. Tired by midday in a way that feels different from eye strain. Your joints ache a little. Nothing you could point to and call pain exactly. More like a background soreness that moves around. Your shoulders today. Your hands yesterday. Your knees on the stairs in a way they didn't used to. Your muscles feel like they did something yesterday that they didn't actually do. That specific feeling of having overexerted, except you didn't. You rested. You were careful. And your body is reporting effort that never happened. Your thinking is slower than you know it should be. Not confused. Not lost. Just delayed. Like the connection between thought and word has a half-second lag that wasn't there before. You reach for a name and it takes a beat longer. You start a sentence and have to find the second half of it somewhere. And then there's the thing that's hardest to explain to anyone. A general sense of being slightly wrong. Not located anywhere specific. Not attached to any single symptom you can clearly describe. Just a persistent background awareness that something in your body is not operating the way it's supposed to. You try to explain this to someone and it comes out wrong. It comes out sounding like nothing. Because individually, none of it is dramatic. Tired? Everyone's tired. Achy? That's just life. Brain fog? Maybe you need more sleep, more water, less screen time. And you nod. Because what else do you say? You don't have a better argument. You just have the feeling, and the feeling doesn't fit neatly into any category anyone gives you. That feeling has a biological explanation. And we're going to get there. Sarah was 34 when she first started noticing something was off. She was a teacher. Active. No significant medical history. She described herself as someone who pushed through things. Headaches, tiredness, the ordinary friction of a busy life. She wasn't someone who went to the doctor for nothing. But this wasn't nothing. It just looked like nothing. It started with fatigue that she couldn't explain. She was sleeping well, eating well, exercising regularly. By all external measures, she was doing everything right. And yet by 2 in the afternoon she was running on empty in a way that felt almost physical, like a heaviness in her chest and her limbs that wasn't emotional, wasn't sadness, was just weight. Then came the eyes. Dry, irritated, sensitive to light in certain rooms. She assumed it was the fluorescent lighting at school. She bought eye drops. It helped a little but never fully. Then the joint aches. Moving, non-specific, worse some mornings than others. Then the brain fog, which was the one that scared her most. She was in front of a classroom every day. She needed to be sharp. And there were days where the sharpness just wasn't there. Days where she'd stand at the board and lose the thread of what she was saying. She went to her doctor. Full blood work. Thyroid panel. Everything came back normal. She was told she was probably stressed. That teaching was a demanding job. That she should consider reducing her workload, prioritizing rest, perhaps speaking to someone about anxiety. She went home and cried in her car. Not because the advice was cruel. Because it wasn't wrong exactly. She was stressed, she was tired, but it felt so profoundly incomplete. Like being handed a bandage when you need a diagnosis. It took 2 more years, 3 more doctors, and a rheumatologist who happened to ask the right questions before Sarah was finally diagnosed with Sjögren syndrome. 2 years of being told, everything looks normal. 2 years of learning to doubt her own body. Her story is not unusual. It is, in fact, almost standard. The medical system is extraordinarily good at catching certain kinds of illness. Infections. Fractures. Tumors. Metabolic crises. The kind of wrong that announces itself clearly in a test result. What it was not designed to catch, and still struggles with, is systemic, diffuse, symptom-led illness that doesn't produce a single dramatic marker. When you go to a standard appointment and describe fatigue, brain fog, joint pain, and a general sense of unwellness, the doctor runs the most common panels. Complete blood count. Metabolic panel. Thyroid function. Sometimes iron, sometimes vitamin D. These are important tests. But they are screening tests, designed to catch common deficiencies and major abnormalities. They are not designed to detect early-stage autoimmune activity or central sensitization. So when those panels come back normal, and they often do in the early stages of both Sjögren's and fibromyalgia, the default conclusion is, nothing is wrong. This is not negligence in most cases. It's a structural problem. Doctors have limited time, limited test budgets, and a framework built around what shows up clearly. Conditions that present subtly, that vary day to day, that require pattern recognition over time. These conditions don't fit cleanly into a 15-minute appointment. And there's something else happening that's harder to talk about but important to name. Women's symptoms have historically been underestimated in medical settings. Studies have documented this across multiple conditions. Women wait longer for pain medication in emergency rooms, are more frequently referred for psychological evaluation before physical investigation, and are more likely to have their symptoms attributed to anxiety or stress before a physical cause is pursued. This is not a fringe observation. It's documented across the research literature. And it means that women experiencing the exact kind of diffuse, hard-to-articulate symptoms that characterize Sjögren's and fibromyalgia are entering a system that is statistically less likely to take those symptoms seriously. The result is a gap. On one side of that gap, a body that is clearly communicating that something is wrong. On the other side, a medical record that says everything is normal. And in between, years. Sometimes a decade or more. Of living with symptoms that are real, that are measurable in their impact on your daily life, and that no one around you can see. Sjögren's syndrome is an autoimmune condition, meaning it belongs to a category of diseases where the immune system, instead of directing its activity outward toward pathogens, turns it inward toward the body's own tissue. In Sjögren specifically, the primary target is the exocrine glands. These are the glands responsible for producing moisture, your salivary glands, your lacrimal glands which produce tears, and glands throughout the mucous membranes of your body. The immune system sends cells, primarily lymphocytes, to infiltrate these glands. Over time, the infiltration damages gland tissue, reducing its ability to produce moisture. This is where the hallmark symptoms of dryness come from. Dry eyes. Dry mouth. Dryness that can extend to the throat, the sinuses, the skin, and in women, to vaginal tissue as well. But here is what makes Sjögren so frequently missed in its early stages. The dryness is often subtle. It doesn't always present as the dramatic, obvious dryness that immediately suggests a condition. It presents as eyes that get uncomfortable in air-conditioned rooms. A mouth that feels slightly tacky after talking for an hour. Difficulty eating certain foods, crackers, bread, things that require moisture to swallow comfortably. A tendency toward dental cavities that seems disproportionate to your dental hygiene. Small things. Easily explained away individually. Almost never connected to each other in the way they need to be. And critically, Sjögren's is not only a disease of dryness. The immune activity involved in Sjögren's generates systemic inflammation, low-grade, diffuse, not always detectable in a standard CRP or ESR panel, but present and consequential. This inflammation is what drives many of the symptoms that feel most debilitating to people living with the condition. Fatigue, profound, structural, sleep-resistant fatigue, is reported by the majority of people with Sjögren's as one of their most impactful symptoms. This is not tiredness that rest resolves. It is fatigue that has a biological source. The immune system is constantly active, and that activity consumes energy. Joint pain and muscle aching, often described as moving, non-specific, varying in location, are also common. The immune activity in Sjögren's can cause inflammation in connective tissue, in joints, and in the muscles themselves. Peripheral neuropathy, nerve involvement, occurs in a meaningful percentage of Sjögren's patients. This can manifest as tingling, numbness, burning sensations, or a general sensitivity in the hands, feet, or other areas. Many people describe this as something that comes and goes, that they never quite know how to categorize, that gets dismissed as circulation or anxiety. And then there is the cognitive dimension. Brain fog in Sjögren's has a biological basis. The inflammatory processes involved in the condition can affect the central nervous system directly, something researchers now refer to as central nervous system Sjögren's. This manifests as difficulty with word retrieval, slowed processing speed, difficulty sustaining concentration, and a general sense that cognitive function is operating below its normal capacity. This is not anxiety. This is not depression, though both conditions can coexist with Sjögren's and share some symptomatic overlap. This is the direct neurological consequence of an immune condition that medicine spent decades treating as primarily a disease of glands. The average time from symptom onset to diagnosis for Sjögren's syndrome is approximately 4 to 7 years. 4 to 7 years of symptoms that are real, that are measurable in their impact, and that have a definable biological cause, before the right name is given to them. Maria was 41 when she was diagnosed. But her symptoms started at 36. She remembered the beginning clearly because it coincided with a promotion at work, a demanding new role that required more travel, more hours, more output. When the fatigue hit, she assumed it was the job. When the joint pain started, she assumed she was sitting wrong, traveling too much, not moving enough. She adjusted her lifestyle. Got a standing desk. Started yoga. Cut back on alcohol. Did everything that wellness culture told her to do when you feel run down. And she felt slightly better. Enough better that she stopped pursuing the question. Then her eyes became a problem. Seriously dry, painful on some days, sensitive to light, difficult to manage with drops alone. She saw an ophthalmologist. He noted dry eye syndrome and recommended preservative-free drops used frequently throughout the day. She asked if dry eye could be connected to feeling generally unwell. He said it wasn't typically related to fatigue or joint pain. He was not wrong in the narrow sense. Dry eye as an isolated condition is not. But he was missing the larger picture. It was a dentist who eventually changed the trajectory. Maria went in for a routine checkup and her dentist noted an unusual degree of decay given her apparently good hygiene. He asked if her mouth ever felt dry. She said yes, actually, constantly. He asked a few more questions and then said, gently, that she might want to be tested for Sjögren's syndrome. She had never heard of it. Her rheumatologist ordered an ANA panel, anti-SSA, and anti-SSB antibodies, and a lip biopsy, the biopsy being the diagnostic gold standard for Sjögren's, which involves sampling minor salivary gland tissue to look for lymphocyte infiltration. The results were positive. She was 36 when her immune system began attacking her moisture-producing glands. She was 41 when anyone gave it a name. 5 years of, maybe it's stress. Maybe it's the job. Maybe it's getting older. Maybe it's nothing. Fibromyalgia is a fundamentally different condition from Sjögren's, but the experience of living with it can feel remarkably similar from the inside. And this is one of the reasons the two conditions are so frequently confused with each other, and so frequently found together. Fibromyalgia is not an autoimmune condition. It is not a disease of inflammation in the conventional sense. It is a disorder of central sensitization. To understand what that means, you need to understand something about how pain works. Pain is not simply a signal that travels from an injured body part to your brain and announces, "This is damaged." Pain is an interpretation. Your nervous system receives signals from the body and processes them, and the threshold at which those signals are interpreted as painful, the volume at which the pain is experienced, is something the nervous system itself regulates. In fibromyalgia, that regulation is dysregulated. The central nervous system, specifically the brain and spinal cord, becomes sensitized. The threshold for pain interpretation drops. Signals that a healthy nervous system would process as neutral or mildly uncomfortable are processed as painful. The volume dial on pain has been turned up, not in the injured tissue, but in the processing system itself. This is why fibromyalgia pain is so difficult to explain and so easy to dismiss. There is no injury to point to. There is no inflamed tissue, no structural damage visible on imaging. The tissue itself is fine. The problem is in the system interpreting the tissue. This is also why fibromyalgia pain has historically been dismissed as psychological, as imagined, as exaggerated, as a manifestation of anxiety or hypochondria. The dismissal was wrong. But it had a surface logic. If nothing is damaged, why does it hurt? The answer is that pain is not damage. Pain is a nervous system output. And a nervous system in a state of central sensitization produces pain outputs in response to inputs that would not trigger pain in a non-sensitized system. Research over the last 2 decades has made significant progress in understanding the neurobiology of fibromyalgia. Functional MRI studies show that fibromyalgia patients have measurably different patterns of brain activation in response to stimuli compared to people without the condition. Neurochemical studies have found altered levels of neurotransmitters involved in pain modulation, substance P, serotonin, norepinephrine, in the cerebrospinal fluid of people with fibromyalgia. This is not a psychological condition presenting as physical symptoms. This is a physical condition that happens to involve the nervous system as its primary site of dysfunction. Fibromyalgia also involves what researchers call allodynia, pain from stimuli that are not normally painful, and hyperalgesia, an amplified response to stimuli that are normally only mildly painful. This is why people with fibromyalgia can experience significant pain from a light touch, from clothing that rubs against skin, from temperatures that other people find merely uncomfortable. It is also why they experience what is sometimes called post-exertional malaise, a worsening of symptoms that follows physical or cognitive exertion, sometimes delayed by 24 to 48 hours. You do more on Tuesday and feel it on Thursday. Your body does not respond to exertion the way a healthy nervous system does. Recovery is slower, less complete, and more costly. The fatigue in fibromyalgia is not simply tiredness. It has a neurological component. The constant processing of amplified pain signals is cognitively and physically exhausting. The brain is doing significantly more work than it should be doing to manage sensory input, and that extra work depletes energy in ways that rest does not fully restore. Sleep disruption is nearly universal in fibromyalgia, and it creates a compounding problem. Poor sleep increases central sensitization, which worsens pain, which disrupts sleep. A self-reinforcing cycle that is very difficult to break without understanding what's driving it. Sjögren syndrome and fibromyalgia are distinct conditions with different biological mechanisms. But they share something important. They both produce systemic, diffuse, hard-to-locate symptoms that standard testing frequently misses. And they occur together more often than chance would predict. Research suggests that a meaningful percentage of people diagnosed with Sjögren's also meet the criteria for fibromyalgia, with some studies estimating this overlap at between 20 and 30%. The reason for this connection is not fully understood, but several theories exist. One is that chronic immune activation in Sjögren's can sensitize the central nervous system over time, effectively triggering the same kind of central sensitization that characterizes fibromyalgia. The constant low-grade inflammatory signaling from an active autoimmune condition may, in some individuals, shift the nervous system into a state of heightened sensitivity that then persists even when the immune activity is managed. Another is that Sjögren's itself has direct neurological involvement, peripheral neuropathy, autonomic dysfunction, and central nervous system effects, that may overlap mechanistically with the central sensitization of fibromyalgia. What this means practically is that someone with both conditions may experience profound fatigue from 2 sources simultaneously, immune activation and nervous system dysregulation. Pain that is both inflammatory in origin and centrally amplified, meaning the immune activity generates real tissue-level signals, and the sensitized nervous system turns up the volume on those signals. Cognitive symptoms from both the neurological effects of Sjögren's and the cognitive load of chronic pain processing in fibromyalgia. Sleep disruption compounded by both conditions. And a symptom picture that is so complex, so variable, and so invisible on standard testing that even a doctor who is looking for one condition may miss the other entirely. This is why the symptom map matters. Not because it diagnoses, it doesn't, and nothing in this video is medical advice. But because pattern recognition is where this starts. Understanding how these two conditions feel from the inside, how they overlap, how they differ, how they interact, is the first tool you have. And it's a tool that belongs to you, not to a test result. There is a specific kind of conversation that happens in doctors' offices, and if you've experienced it, you know exactly what I mean. You've prepared. You wrote things down. You have the timeline of symptoms, the specific complaints, the things you've noticed and tracked. You've done your research, you've tried to be precise, you've resisted the urge to minimize. And then something shifts in the room. It's subtle. The doctor's posture changes slightly. The questions become a little more general, a little less curious. There's a mention of stress. A mention of anxiety. A mention of getting enough sleep. The appointment moves toward its conclusion and you feel it happening, the door closing before you've gotten through it. You leave with nothing new. Maybe a referral that takes 3 months to materialize. Maybe a recommendation to track your symptoms in a journal. Maybe just, come back if anything changes. And you sit in your car in the parking lot and feel something that is hard to describe. Not quite anger. Not quite grief. Something in between. The particular exhaustion of having tried to be believed and not quite making it. This is not a rare experience. It is described, in almost identical terms, by women with Sjögren's, with fibromyalgia, with lupus, with endometriosis, with dozens of conditions that are systemic, diffuse, and hard to quantify. The dismissal does damage beyond the obvious. It doesn't just leave you without answers. It introduces doubt into your relationship with your own body. You start second-guessing your symptoms. Minimizing them before anyone else can. Prefacing every description with "I know this sounds weird" or "maybe it's nothing." You do the doctor's work for them before you even get there. Some women stop going at all. Not because they've given up on their health. Because the cost of being dismissed again is higher than the cost of just managing alone. That is the real damage of the medical validation gap. If you have been told everything is normal, but you do not feel normal, that matters. The absence of a diagnosis is not proof that nothing is wrong. It often just means the right questions haven't been asked yet, the right tests haven't been ordered, or the doctor looking at your chart isn't looking at the right picture. You are not too sensitive. You are not making it up. Your body is communicating something real. And the fact that you have kept looking for answers, the fact that you are still looking, right now, watching this, that is not weakness. That is exactly the right instinct. If you've been tracking symptoms that feel real but won't connect into anything clear, type symptom map in the comments right now. I'll send you the free map built specifically to help women identify these patterns. The ones that slip through standard testing. The ones that feel impossible to explain until you see them laid out. Because naming what's happening is the first step to actually doing something about it. One of the things that makes both Sjögren's and fibromyalgia so difficult to understand, and so difficult to explain to other people, is that they both involve the nervous system in ways that are not intuitive. We tend to think of illness as something that happens in a specific place. A broken bone is in the leg. An infection is in the lung. A tumor is located somewhere. But nervous system involvement doesn't work that way. When the nervous system is dysregulated, the effects are diffuse. They show up everywhere and nowhere. They shift. They change. They are inconsistent in ways that feel suspicious, even to the person experiencing them. In Sjögren's, nervous system involvement takes several forms. Peripheral neuropathy, damage or dysfunction in the nerves that run from the spinal cord to the extremities, is common. This can feel like tingling, burning, numbness, or a generalized sensitivity in the hands and feet. Autonomic neuropathy, affecting the nerves that regulate automatic functions like heart rate, blood pressure, digestion, and temperature regulation, is also documented in Sjögren's. This is why some people with Sjögren's experience dizziness when standing, gastrointestinal symptoms, or temperature dysregulation that seems disconnected from anything obvious. Central nervous system involvement in Sjögren's, affecting the brain and spinal cord directly, is less common but documented. It can manifest as cognitive changes, mood dysregulation, and in some cases more significant neurological symptoms. In fibromyalgia, the nervous system is the primary site of the condition. The dysregulation is central, meaning it's happening in the brain and spinal cord. But the autonomic nervous system is also frequently involved. Many people with fibromyalgia show signs of autonomic dysfunction, difficulty regulating responses to stress, position changes, temperature. The body's automatic regulation system is not working the way it should. This nervous system involvement explains something that many women with these conditions find deeply confusing: the variability. Good days and bad days. Weeks where things feel almost manageable and then a crash that seems to come out of nowhere. Symptoms that are worse after stress, worse after poor sleep, worse after too much activity, but also sometimes worse for no identifiable reason at all. This variability is not inconsistency in the sense of imagining symptoms on bad days. It is the natural behavior of a sensitized or dysregulated nervous system responding to internal and external inputs. Stress activates the nervous system. Poor sleep sensitizes it further. Overexertion overwhelms its capacity to regulate. And the result is a flare, a worsening of symptoms that has a biological basis even when it has no obvious external trigger. Understanding this doesn't make it easier to live with. But it does make it possible to see it clearly, and seeing it clearly is what makes it possible to stop blaming yourself for it. There are specific patterns in Sjögren's and fibromyalgia that, when you know to look for them, are recognizable. But most women don't know to look for them. And most doctors don't look for them unless they are already suspecting the diagnosis. The morning stiffness pattern. Both conditions frequently produce stiffness that is worst in the morning and improves, sometimes significantly, as the day progresses. This is different from the stiffness of simply being sedentary. It has a characteristic quality, a heaviness in the joints and muscles that takes time and movement to ease, and that is present even when the previous day was restful. The post-exertional pattern. Activity that should be manageable produces a delayed worsening of symptoms, fatigue, pain, fog, that appears 12 to 48 hours later rather than immediately. This pattern is characteristic of central sensitization and is one of the clearest distinguishing features of these conditions from ordinary tiredness or deconditioning. The flare pattern. Symptoms worsen during and after periods of stress, not just emotional stress, but immune stress, illness, infection, physical stress, travel, disrupted sleep, and hormonal stress, menstrual cycle, perimenopause. Women with Sjögren's frequently report worsening symptoms in the luteal phase of their cycle. The connection between immune activity and hormonal fluctuation is documented in autoimmune research, though it is rarely discussed in routine care. The trigger sensitivity pattern. Fibromyalgia produces sensitivity to environmental inputs that most people process without difficulty. Noise, light, temperature, certain textures, certain smells. This is not anxiety. It is allodynia and central sensitization manifesting in the sensory processing system. The invisible morning pattern. Both conditions can produce a gap between how someone appears and how someone feels. Someone with Sjögren's or fibromyalgia may look completely well. They have learned to present well because they have no other option. The alternative is constantly appearing to be falling apart. But the effort of maintaining normal function through these symptoms has a cost that is invisible to everyone around them. Recognizing these patterns, in yourself, in your own history, in the way your symptoms move and cluster and respond to different conditions, is the beginning of being able to name what you're dealing with. There is something that happens when you finally have a name for something you've been feeling for years. It is not a cure. The name doesn't make the symptoms stop. It doesn't immediately produce a treatment that fixes everything. It doesn't erase the years spent being told nothing was wrong. But it does something that is, in its own way, as significant as any medical intervention. It separates the symptoms from the self-doubt. When you don't have a name, the symptoms and the doubt are fused together. Every bad day is also a day of wondering if you're being dramatic. Every moment of pain or fog or exhaustion carries an asterisk. But is it real? But am I sure? But what if they're right and it's just stress? When you have a name, or even when you have enough clarity to recognize a pattern and say, this looks like something, the doubt starts to separate. The symptoms are still there. But they belong to a condition, not to a character flaw. They are something happening in your body, not something happening because of how you are. That separation matters clinically, not just emotionally. Women who can describe their symptoms in terms of patterns, who can say I have post-exertional worsening that typically appears 48 hours after activity rather than just I get tired, are more likely to be taken seriously, more likely to have the right investigations ordered, more likely to reach a diagnosis. Language is not just emotional validation. Language is a clinical tool. And that is what the symptom map is built for. Not to diagnose. Not to replace a doctor. But to give you the language to describe what's happening in a way that can be heard. To help you recognize patterns in your own experience that you might have been dismissing for years. To move from something is wrong to I think I know what this looks like, and that matters. There is more to this than what we've covered here today. There are patterns in how Sjögren's and fibromyalgia progress over time. There are specific questions that move a diagnostic conversation forward, and specific things doctors miss in the first appointment that, if you know to raise them, can cut years off the diagnostic journey. There are connections between these conditions and other things that frequently accompany them: autonomic dysfunction, mast cell activation, hormonal shifts, sleep disorders, that form a picture that is larger than any single diagnosis. And there are things you can do, right now, before you have a diagnosis, to begin understanding what your body is telling you. In the next video, I'm going to walk through what that recognition process looks like in practice, the specific questions, the specific patterns, what to bring to an appointment, and what to do when you leave without the answers you needed. But if something in the last several minutes felt familiar, if you heard yourself in Sarah's story, or in Maria's, or in the description of that parking lot moment after an appointment that didn't go the way you needed, don't wait for the next video. The gap between something is wrong and I finally know what to ask for is where years get lost. And the symptom map exists to close that gap. Type symptom map in the comments right now and I'll send it to you, free, immediately. If your tests are normal but your body doesn't feel normal, this map was built for exactly that. If you've been feeling off but can't explain it to a doctor, this gives you the language to try again. If you know someone who has been dismissed, who has been told everything is fine while clearly not feeling fine, share this video with them. Because one of the most isolating parts of these conditions is the sense that no one else could possibly understand what you're describing. Someone you know might need to hear, you are not imagining it. Subscribe, because next week we go deeper into what the patterns look like up close, and what to do when you finally recognize them in yourself.